Welcome to everyone listening this video. Today we present a history of uh, Mrs. Salima, a 23-year-old woman, housewife, non-hypertensive, non-diabetic, non-smoker, and non-alcoholic, resident of Karachi, presents with multiple purpuric rash over her limbs and trunk for 3 days. She states that she was reasonably well 3 days back, then she notices a few red spots in her limbs 3 days back, which gradually increases in number, involving both limbs and trunk. She is well and fit and has no fever, epistaxis, gum bleeding, hematuria, weight loss, abdominal pain, arthritic pain, and vaginal bleeding, but had excessive menstrual blood loss in last period. She has no significant past history, family history, and drug history. On examination, the patient has multiple non-blanching bright red purpura in limbs, trunk, and buccal mucosa, but no fever, anemia, lymph node, bony tenderness, and organomegaly. So my provisional diagnosis is idiopathic thrombocytopenic purpura. Provisional diagnosis is ITP. Differential diagnosis, I will put aplastic anemia, acute leukemia, and viral infection like dengue, hemorrhagic fever. So the first question the examiner may ask, why do you consider this diagnosis? Well, I'll say a 23-year-old woman presents with multiple purpuric rash over her limbs and trunk for 3 days without any other symptom like fever. She has multiple non-blanching bright red purpura in limbs, trunk, and buccal mucosa, but no fever, anemia, lymph node, bony tenderness, and organomegaly. So I consider this diagnosis. And examiner might ask that why do you not consider aplastic anemia? Well, the answer, this patient has feature of only thrombocytopenia, that is purpura, but no anemia and feature of leukopenia like fever. So aplastic anemia is not suggestive. So the examiner may ask that why is this not acute leukemia? This patient is not toxic and has no anemia, fever, bony tenderness, lymph node adenopathy, and organomegaly. So, now how can you investigate this patient? I will go for blood tests like differential count, hemoglobin, ESR, CBC, in which includes the platelet count as well. Then the next will be bleeding time and clotting time, bone marrow study, antibodies directed against target antigens on the glycoprotein 2b3a or glycoprotein 1b9 complex. So, what is your expectation in full blood count? Reduced platelet count is the expectation in ITP. What is the confirmatory investigation to establish diagnosis? Bone marrow study in case of ITP, and there will be increased megakaryocytes in bone marrow examination. Now, if there is reduced megakaryocyte or bone marrow hypoplasia, then it is suggestive of leukemia. Now, how would you treat patient of ITP? As the patient is well, he just has purpura 3 days, So we'll observe the patient. Observation is the first choice as the disease is self-limiting. If purpura increases or bleeding from any site, then steroid, oral prednisolone 1 milligram per kg for 2 weeks, followed by tapering over 3 to 4 weeks. So, what is ITP? It is an acquired disorder leading to immune mediated destruction of platelets and possibly inhibition of platelet release from the megakaryocyte. There are two types of ITP based on the duration, that is acute ITP. It occurs in children, commonly follows an infection and is self-limiting. The second type is chronic ITP. It occurs in adults, insidious in onset, chronic course, more commonly affects females, unusual to have history of preceding viral infection. Now, what is the mechanism of ITP? ITP is due to autoimmune mechanism mediated by autoantibodies, most often directed against the platelet membrane glycoprotein 2b3a, which sensitizes the platelets, resulting in premature removal from the circulation by cells of the reticuloendothelial system. So this is the mechanism of ITP. Now, what are the common presentation of ITP? The common presentation in ITP is purpura, petechiae, bruises, and it is common in females, and it can present as gum bleed, skin bruisability, menorrhagia. So if we further focus on purpura, purpura is extravasation of blood in skin and mucous membrane which does not blanch on pressure and undergoes progressive color change. What history would you take in case of ITP? History of bleeding, that is purpura and gum bleeding. History of respiratory infections 2 to 3 weeks before. So how can we differentiate between acute ITP and chronic ITP? Acute ITP is common in children and it is equal in both sexes, male and female. It is of acute onset, self-limiting, and commonly follows a respiratory illness, while the chronic ITP occurs in adults, more common in females, insidious in onset, and does not have any history of respiratory infection. The treatment of ITP is supportive, that is blood transfusions, platelet transfusions. There are certain specific treatment like steroids, oral prednisolone at least 2 weeks followed by tapering over 3 to 4 weeks. The dose in children is 2 milligram per kg, while the dose in adults is 1 milligram per kg. Indications: moderate to severe purpura, bruising or epistaxis, platelet count less than 10,000. These are the indications of steroids in case of suspected ITP. But even if steroids fail and there is no response, then we go for IV immunoglobulin. And if immunoglobulin uh, doesn't work, then splenectomy. And if immunoglobulin, steroids, and splenectomy fails, then we have to go for immunosuppressive therapy like vincristine, azathioprine, cyclophosphamide. Rituximab used in refractory cases who doesn't respond to steroid and splenectomy. Now, is there any indication of platelet transfusion in ITP? This is a very important question. Yes, of course, if there is severe bleeding, not controlled with steroid, like persistent epistaxis, GI bleed, retinal hemorrhages, intracranial bleeding, and before splenectomy, we can transfuse platelets. Now, what are the indications of splenectomy in a patient of ITP? So, a chronic case of ITP with two relapse or life threatening bleeding not controlled by other means. First 4 to 5 months of pregnancy when steroid failed to induce remission. So we can give in these three conditions, like chronic cases with two relapses, life threatening bleeding, and in pregnancy when steroids fail to induce remission. These are the indication of splenectomy in ITP. Chronic course with relapse and remission is the rule in ITP, but there may be no relapse. So, if a female patient develops menorrhagia without any purpura in ITP, how would you treat? Suppression of menstruation by continuous use of oral contraceptive pill. So this is the mainstay of treatment. So examiner might ask that oral contraceptive pills indication in an unmarried girl. What are the medical indications of oral contraceptive pills? So the indications are menorrhagia due to ITP or bleeding disorder, or thrombocytopenia due to any cause, dysmenorrhea, polycystic ovarian syndrome, and dysfunctional uterine bleeding. These are few points regarding ITP discussion. We have in our differential diagnosis, that is dengue viral hemorrhagic fever, Epstein-Barr virus, and hyperviscosity, bleeding disorder, blood thinning medicines. We have to inquire in case, and ITP is a diagnosis of exclusion. So we have to rule out chronic kidney disease, chronic liver disease, in which both there are thrombocytopenia, and we have to rule out hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. So these are few important differentials in case of ITP. Now, even eczema is a differential. Autoimmune diseases like SLE, and these are, they need to be ruled out. There is a term secondary ITP in case of viral infections like hepatitis B, hepatitis C, IV drug abuse, or any surgical procedure that leads to secondary ITP, high risk sexual behavior, and unscreened blood transfusions. In case of any lumps and bumps in the body, we have to rule out. So thyroiditis, we have to rule out. Any drugs like NSAIDs, aspirin, clopidogrel, heparin, epivol, any chemotherapeutic drugs, these all can cause a secondary ITP. So on blood picture, if all cell lines are depressed, then and cases there is patient is bleeding. So if all cell lines are depressed, it's aplastic anemia. If one cell line like thrombocytopenia is depressed and there is a case of bleeding, then it is most probably ITP, secondary to drugs or any malignancy. So this was the short case of purpura, and the workup we have discussed. We have now examiner may ask that splenomegaly in ITP, is it possible? Yes, of course. In ITP, if it is secondary ITP, there is splenomegaly, but if it is primary ITP, then there is no splenomegaly. And for primary ITP, one investigation to for diagnosis, investigation of choice is autoantibody that is against the glycoprotein 2b 3a, and primary ITP is diagnosis of exclusion. So these are the medicines again: prednisolone, rituximab, eltrombopag, that is the thromboplastin, and fostamatinib, tyrosine kinase inhibitor. And splenectomy is associated with 70% cure rate. So after splenectomy, if still the patient is having thrombocytopenia, then we have to go for PET scan to rule out any accessory spleen, and autologous stem cell transplantation is also considered in the end for ITP. So target platelets in delivery, when there is patient plan of delivery, and more than 6 platelet concentrate or 1 mega unit and normal vaginal delivery, it's planned. So IV steroid is safe, IVIG is safe, and steroids can be given, IVIG can be given in second and third trimester of pregnancy. Splenectomy can be done in second trimester and onward. All major surgeries can be made if platelets counts are more than 100,000. So Evans syndrome is a disease that is associated with ITP, like there is warm autoimmune hemolytic anemia, splenomegaly, ITP. The treatment strategy for Evans syndrome is IVIG plus steroids plus immunosuppression plus splenectomy and transfusion. Now there comes a protocol of splenectomy. So vaccines that are given 2 to 3 weeks before splenectomy is H influenza, meningococcal and pneumococcal. Then yearly influenza vaccine, repeat 5 yearly pneumococcal vaccine, the malaria prophylaxis plus oral penicillin if allergic, uh, uh, and if penicillin allergy, then macrolides can be given. So these are few vaccinations and the splenectomy protocol. What is a relapsed ITP? If ITP relapse after 3 months of treatment, so this is relapse and persistent, no change or improvement after 3 months of treatment, and chronic if the thrombocytopenia persists after 1 year of treatment, then it is chronic ITP. So we have to maintain the platelet count. The target is more than 30,000. So this is the minimum. So for TTP, the ADAMT S13 is decreased. That is the treatment. That is the investigation. And TTP can be treated with plasma exchange and Raplasizumab. HUS can be treated with plasma exchange and Eculizumab. So there may be qualitative platelet defects like in Bernard-Solier syndrome and Glanzmann syndrome, that is also a qualitative platelet defect, and in that case the antibodies against the glycoprotein 2b 3g is common. BT is the bleeding time is for diagnosis of Glanzmann syndrome, and ristostatin assay is done in that case. HIT is a term that heparin induced thrombocytopenia. After starting heparin for 5 to 14 days, there is 50% drop or more than 50% drop in platelets, but may occur after 30 days. So this is heparin induced thrombocytopenia. So the lab to diagnose heparin induced thrombocytopenia is antibody against platelet factor 4 and serotonin release assay. These are two tests which are conducted to diagnose heparin induced thrombocytopenia, and the treatment is danapride, bivalirudin, fondaparinux can be used as alternate to heparin. So these are few diseases of which comes in the differential of purpura. Our basic uh, case was ITP. So thank you very much.